Right, level 4s, this is the practice exam. So for those who are not in class today, you'll be able to watch this as an example of what to expect when you take your examination on either the 16th or 17th of January. The examination will take place in this room, CE 102. Please make sure you are here 15 minutes before your assigned time. When you are called in, you will be called into this room, which will be split into two parts. The front part and then the exam part. The front part will have 3 desks. You will sit at a desk and you will be assigned a joint. And that joint will either be ankle or foot, knee or hip. And you will have either 10 or 15 minutes to make notes, 15 minutes for those who get extended time. You're entitled to bring that sheet that you make notes on into the exam part, and only that sheet, nothing else. So on that sheet you may want to record things like how you would classify the joint, key bony markings, any notes you want to make about muscles, where they originate, where they insert, nerve and blood supply, how you would test them, and also think about what you may want to talk about when we give you a movement task to think about at the end of the exam. So as you can see on the board behind me is the marking grid. So what the assessor will do is put your name in, your final mark, and the joint that has been assigned. So the first part of the exam will look at how your ability to classify the joint. Your model will be waiting for you when you come into the exam part. So I'm going to assess myself, and the joint that we're going to use as an example is the knee joint. Okay. I've got students sitting behind Bradley, who's filming, and they are going to use the marking grid to assess. Please make sure that you do the same at home. So go through the marking grid. Where do you find the grid? It's on Moodle, either under week 12 or under the extended learning tab. I'm going to place everything under week 12, including this video recording. So my model is waiting, and your model will wait until you are ready for the part where you need to work on the live model. So I would come in, my assessor would be waiting for me. Behind me is a table with the anatomical models that I can use. There will also be the bone models or skeleton. So you are free to use any models that you are comfortable working with. And the first question my assessor would ask me is, hello Earl, you look a bit nervous, relax. Not here to catch you out with a funny smile on their face. We're here to test your knowledge. Okay. So the first thing, Earl, can you classify the knee joint for me? Well, there are a number of joints that make up the knee joint, but the main joint is the articulation between the femur and the shin, tibia. And that is a synovial bicondylar modified hinge joint. It allows flexion and extension in the sagittal plane across the horizontal frontal axis. It is a modified hinge joint because it also allows slight medial and lateral tibial rotation that occurs through a longitudinal or vertical axis across, some say, the frontal plane, others would argue it's a transverse plane. The range of motion for flexion is roughly up to 130 or 140 degrees. Extension could be -10 to -15. We get slightly more lateral rotation of the shin or tibia, because sitting above the shin is a cartilaginous disc, a meniscus. On the lateral side it's O-shaped, which actually enables it to pivot a little bit more. So we get up to about 30 degrees of lateral rotation and roughly 20 degrees of medial. The other joints that make up the knee, we've got the kneecap, the patella, articulating with the femur. So that's the patellofemoral joint, and then we've got the proximal fibular tibia joint. Although that doesn't actually play a role within the knee itself, it's merely a site that supports the knee onto which ligaments would attach. Okay, so you've told us about the range. Could you tell me what limits the end of flexion of the knee? So what would that end range be? Well, when we flex our knee, it would be two muscles. The gastrocnemius has two heads, a medial and lateral head, and they would meet the hamstring group at the back. So if I had to flex, that particular muscle bulk would limit the range, as well as the posterior cruciate ligament, which controls how far back the tibia moves in relation to the femur. So those would be the limiting factors in flexion. When I extend, it would be a hard end feel because we would have the condyles of the femur articulating with the cartilaginous discs that sit above the shin, tibia, and they would actually limit or stop the range. So we can't actually extend further, although some people may be able to hyperextend their knees. Okay. The passive range on the patient, if it's okay, I will show you that, demonstrate that when I measure the range. Okay, so that could be measured when we move on to the next part of the exam. The assessor would then ask you to identify some of the key bony markings. So if we start out, Earl, could you please identify for me the medial epicondyle of the femur? The medial epicondyle sits superior to the condyle of the femur. It is also the attachment point of the medial collateral ligament, and it sits over there. Over here we have the two large condyles of the femur. Between that we have the intercondylar surface, or notch, and that's the space that the posterior aspect of the kneecap sits, articulates. On the lateral side, we've got the lateral epicondyle, the lateral condyle, where the tibia, just the superior part, is where the patellar ligament attaches, is known as the tibial tuberosity. On the medial side of the femur, at the distal end, we've got a little marking there, that's the adductor tubercle. And above that, we've got the medial supracondylar ridge. On the lateral side, we've got the lateral supracondylar ridge. On the posterior side, the back of the knee is known as the popliteal fossa. And on the medial side, we've got the tibial tuberosities. And that's the medial side. On the lateral side, we've got the lateral tibial tuberosity. Moving up here, we've got Birdie's tubercle, and over here, just down here on this marking, is we've got the pes anserine, where some of the muscles on the posterior aspect insert, and that means goose's foot. Okay? So those are the key bony features that are pointed out on the model, some of them. Now your assessor may ask you to locate or palpate them on the live model. So my live model, thank you very much. Hello, I'm Earl, and I'm going to be working on your knee this morning. We're not going to do anything more than just test your knee and assess it. Is that okay with you?
Yeah, that's fine.
I'm going to wash my hands, but my hands are clean. What I would like you to do is just sit on this plinth. I've just checked the brakes on, so it's stable. If you wouldn't mind facing that. Great. And then if you could slowly lie down so you are on your back. And just come forward. Are you comfortable there? Okay. What I would like you to do is bend your knee, please. Any knee, that's fine. And the assessor may ask you to palpate the joint line. So what I'd be feeling for is the joint line between the femur and the shin. And the way that you can palpate this, locate your bony markings. So what I may be asked to find is the kneecap, the patella. So I would make sure I can find the superior border of that, the medial and the lateral border and the apex coming down. And between that, palpating quite smoothly the gap between the femur, the femoral condyles, and the shin tibia. Okay? Your assessor may also ask you to palpate the tibial tuberosity over there, and also make sure that you can palpate the condyles and the epicondyles above that. You would also be asked to point out on an X-ray some of those markings. So for example, the joint line, the patella, the medial epicondyle, the medial condyle of the femur, the lateral epicondyle, the lateral condyle of the femur, the tibial plateau, the intercondylar ridge, or better known as the intercondylar, what's that word? Eminence. That's right, eminence. Okay, that's fine. The fibular head, the proximal fibular tibia joint, and the surfaces onto which the cartilaginous discs would sit. That would be the lateral meniscus sitting over there and the medial one over here. How do I know that? Because the tibia is the medial bone of the shin. Okay. So that would take care of part 2. The one thing I haven't done is actually explained the concave and the convex parts, so I'll do that now. The concave part would be, if we look at this joint, the tibia, so it forms a cave. The convex part would be the condyles of the femur, and that allows for flexion as the condyles move forward, and extension as the condyles move back to straighten the leg. The tibia, as we said, could rotate slightly to the medial side, has slightly more rotation on the lateral side. If we looked at the kneecap, the convex part would be the posterior part, the concavity would be the intercondylar notch. So that would be that. So that's part 1 and 2. The next part would be part 3, where your assessor would ask you to talk about the ligaments of the knee, okay, in this case. So what I would explain here, that there are 4 ligaments. 2 are external to the capsule of the knee, 2 are found inside the knee. So the 2 inside the knee are known as the intracapsular ligaments of the knee. The ones on the outside are the extracapsular ligaments of the knee. So the key ones, the medial collateral is much thicker and longer than the lateral collateral, and that's an important ligament because it stops any force bringing the knee into the medial side. So if we wanted to stretch on that, we would move the tibia, the femur inwards. The lateral collateral ligament prevents any force moving the shin. So if I wanted to stress on that, what I'm talking about here, if I could just ask you to bend, it would stop that kind of force, okay? Bringing the tibia in, where the medial one would stop the tibia moving outwards. Inside the knee, the anterior cruciate ligament is so named because of its attachment to the shin or tibia. So it attaches anteriorly, then it comes up and winds itself back to attach on the lateral posterior surface of the femur, whereas the posterior cruciate ligament attaches posteriorly on the shin or tibia, and then winds its way superiorly to attach on the posterior medial aspect of the femur. The intracapsular ligaments control how far forward the tibia moves, for example the anterior one in relation to the femur. The posterior would control how far back the tibia moves in relation to the femur. What I've been asked to do now is to test these or palpate them. So what I'm going to ask my model to do is bend her knee. It's difficult to palpate, so let's just take one, the anterior cruciate ligament, to test that. Fingers at the back of the knee. I'm sitting on my model's foot, so I don't want her foot moving. And what I'm really trying to do is bring the tibia forward. If the tibia did move forward, laxity in that joint, there may be issues with that. But what we're trying to do is replicate the action, moving the shin forward. If I was to test the other one, the posterior cruciate ligament, I would apply a posterior force, so from anterior to posterior, trying to translate the tibia backwards. Right. The next part of the grid is about muscles. We're just going to do one for the purpose of this mock exam. And the muscle that my assessor has given me is the rectus femoris. Okay? So the first question, can I identify that? Okay. So the rectus femoris is part of the anterior group of muscles. It's part of the quad group. It's one of the 4 quadricep muscles. The belly is located over here. It's bordered from the medial side by the vastus medialis, on the lateral side by the vastus lateralis, and deep to the rectus femoris is the vastus intermedius. The rectus femoris has got, some texts that I've read have said it's got 2 heads. The anterior part of the head originates from the anterior inferior iliac spine. So just pointing that out on the skeleton, what I'm saying is that it starts over there. The posterior head, there's also a part that can come from what we call the supraacetabular groove. The fibers then descend to attach onto the kneecap, the patella, which is also a sesamoid bone. It attaches through a tendon known as the patella tendon. Then the kneecap is anchored within the tendinous soft tissue through a ligament onto the tibial tuberosity. So it attaches on the hip and inserts on the knee. Because it crosses 2 joints, its main action is that it is a primary extensor of the leg, but it also has action in flexing the hip. The blood supply to it is the femoral artery and femoral vein. The nerve supply is the femoral nerve. The root of that is from the lumbosacral plexus, L2, L3, and L4. The femoral artery is a branch of the aorta. It comes down through the through the hip and pelvis. It's a branch of what we call the external iliac artery, branches into the femoral artery as it passes through. When I went to the anatomy lab, they spoke about the femoral triangle. Its border superiorly is the inguinal ligament, laterally the sartorius, and medially the adductor longus muscle. The way that I've learnt on this is the concept of navy. Thinking about the Y on front, so I've got the nerve for N, the A for the artery, the V for the vein, and the Y for the Y front, which you haven't asked me about. But the femoral artery then comes down and supplies the rectus femoris muscle. It comes through what we call the adductor canal. There's a little opening just under that, which is called the hiatus, where it wraps its way around and supplies the back of the knee. So it actually goes from anterior to the posterior surface. And at the back of the knee it branches into the popliteal artery, which then branches into the anterior tibial artery and the posterior tibial artery. The nerve supply, as I said, is from the lumbosacral plexus, and it's the femoral nerve, L2, L3, L4. How would I test on that? Because it's a major extensor of the knee, there are a number of ways. If I could ask you to sit forward, I'd like you both legs hanging over, keeping her knee flexed. My idea from a break test, a mid-term range test, as I said, the range for flexion of the knee is roughly 135 degrees. So I would want to get her to the mid-range, that because this is an extensor muscle on the anterior part, I would sit her leg like that and ask her to hold it there. And if she is able to that, I would grade that as strong. If I wanted to do another test and apply pressure to it, I would ask her to try and keep pointing her toes towards the ceiling. Okay, so you're going to do, make sure you hold the holding on, you're safe. I'm just going to support there. My ideal, I would apply an opposing force, so try and force the knee back into flexion. She would try and maintain extension there. So I'm doing that. And that is strong, so I would rate that as strong. To find the belly, I would ask her there as well to straighten her knee, leg and contract these muscles, and I would palpate, feeling the belly of that muscle. Okay. So that would be the range. You could expect 3 muscles there. Each one is worth 11 marks. What you'd be asked to do, can you find that on the muscle model? Can you palpate, identify on a patient as well? Okay, so we'll be asking you both of those. The next part of the exam, can we measure the range? So once again, could I ask you to lie on your back? And the range we're going to measure now is flexion, the knee. And here I'm going to, before I measure the range, I just want to make sure my patient can move the knee effectively. Actively, I would ask her to bend her knee, any knee. And my instruction would be, can you drag your heel towards your buttocks, please? And that should roughly be actively anything between 125 to 135. Passively, if I could take control, feel that? Knee, I will take that a little bit further until I get to the end feel, making sure that the foot is planted securely. Let's actually do it on this side. So I would make sure the foot is planted, it's not raised, and I would try and think about that end feel, which may be soft because we've got the heads of the gastrocnemius meeting some of the hamstring muscles over there. The way I would then measure this using a goniometer is look for my key markings here. So starting at neutral, bending her knee, asking her to drag her heel towards the buttocks, feeling for the lateral epicondyle of the femur, placing the apex or the axis of the goniometer over there, the non-moving arm along the midline or the long shaft of the femur, the movable arm aligned up with the lateral bone of the leg, the fibula, and I would read that currently as roughly 115 degrees. So she's got limited range in there. Okay? So that's what I would use as my mark. Okay. The next part is the last part that is examined, and that deals with the functional analysis. And what I've been asked by my assessor is to think about a squat, standing straight, squatting down, and coming back up. What's happening out of the knee. All right? So if I could encourage my model to stand up. When we're doing this as part of the exam, make sure that your model is stable. If she needs to hold on to the plinth, make sure it's there, especially if you're doing ankle or foot. You may be asked this type of motion, make sure that you have a support in place. So what I would like you to do is stand up straight. What you're going to do, you're going to bend your knees as though you're sitting down, keeping your back straight, go down as far as you can, and then come up again. All right? So as she starts out, we have extension at the knee, so we'll get the quadricep muscles contracting in a concentric way, which means the muscle fibers shorten under strain or gravity. So that's what happens where the posterior compartments, the hamstrings are lengthening, so they are contracting in an eccentric way. As we get to the middle of that squat, and she holds, that's where we would see an isometric contraction. There's just a hold. And then finally, as she comes back up, we'd get a reversal there. So in order to flex our knee, we would need to have the hamstrings contracting in a concentric way and the quads contracting in the opposite way, which is an eccentric. As we come up about 20 degrees of flexion of the knee back into an extended pose, we get the screw home mechanism coming into effect, where the condyles of the femur lock into the tibia to support that motion as we come through. Also having an effect in controlling this would be the anterior and posterior cruciate ligaments, controlling how far forward the shin moves in relation to the femur. Okay? That's where the exam would end, right? The last two parts on the marking grid, thank you. The last two parts are not examined in terms of it, but the assessor will make judgments against: have you answered questions? Have you looked the part? Have you used appropriate language when you are communicating with a model? And then, is there any evidence to support that you've done some additional learning? So that's where additional marks will be assigned, and the whole exam is out of 75 marks.